Everybody. Welcome to our presentation. This is over diversity in mental illness. This is done by myself, Lexi, along with Dylan, Marlene, and Savannah. Purpose of this presentation is to equip community healthcare providers to better serve diverse populations by integrating cultural awareness, mental health advocacy, neuroscience, and faith all together. So today we're going to be exploring how different cultures shape the expression of mental illness, influence help seeking and perceptions of others, and how stigma and the whole person care impact treatment outcomes.
Perfect. And then I will be talking about why it matters. Mental health is not experienced the same way across all cultures. In some cultures, distress is more often seen as expressed emotionally, such as sadness or anxiety, while in others, it is expressed physically, like a headache or even fatigue. Culture plays a major role in how individuals understand and also communicate their symptoms with their communities and families. Without cultural awareness, providers may misinterpret symptoms, leading to misdiagnosis or ineffective treatment. For example, somatic symptoms might be overlooked if a provider expects an emotional response. Understanding cultural difference allows providers to better support clients and create more effective, culturally responsive treatment plans.
Okay. For our kind of first main area, cultural differences in expression of mental health, this slide is going to highlight how mental illness is expressed differently across cultures. Again, just reminding us there's no single correct way to experience or communicate distress. Our first source here in research by Pisanelli and Simon shows that somatic and emotional symptoms are deeply interconnected across patients worldwide. Physical symptoms like fatigue or pain are not separate from emotional distress, but part of that same experience. Importantly, their findings challenge a common bias that there's no evidence that people in non-Western or developing countries somaticize more than others. This assumption can reflect cultural misunderstanding rather than reality. Next, we consider cultural idioms of distress, which are culturally meaningful ways of expressing suffering. For example, phrases like "I'm thinking too much" are used in many communities to describe emotional strain. And just because these expressions are different than maybe other people would describe them, they're not lesser or indirect. They're still valid and culturally grounded ways of communicating that to many people feel safer and less stigmatizing. We also see cultural concepts of distress, which may overlap with diagnoses like depression, anxiety, or PTSD, but are not identical to them. So these experiences often carry social, moral, and spiritual meaning that Western diagnostic systems don't fully capture, which just continually reminds us that mental illness is not just biological or psychological, it's also cultural. And then the last research I have on this slide is looking at Yik and Chen's work, which found that Chinese participants often used emotional language to describe distress, sometimes even more than somatic language. Additionally, individuals with stronger cultural identity used clearer emotional terms, which highlights how identity can shape expression. This reinforces that culture doesn't limit expression, it just shapes and gives meaning to it in different ways. Clinically, especially in mental health, this calls us to practice cultural humility. We need to listen for how clients describe their experiences in their own words, attend to their beliefs about mind and body, and recognize the cultural frameworks that they are bringing. It also means that we need to adapt our assessments and interventions so they align with the client's cultural context, rather than expecting clients to fit into a Western model of mental health.
Moving into the cultural influences on help seeking and coping, cultural competence is really important in counseling. It means understanding a client's cultural background, their lived experiences, and being able to adjust how we communicate and provide support based on that. Culture also shapes how people see themselves. In collectivist cultures, people tend to prioritize family and group harmony, while in individualist cultures, independence is emphasized. This impacts how people express emotions, cope, and even approach therapy. And that information was from the article by Jiao. There are also major barriers to seeking help, especially stigma. Many individuals delay or avoid mental health services because of fear of shame, which can make their symptoms worse over time. For immigrant youth, acculturative stress is another key factor. Adjusting to new cultures while trying to maintain one's identity can create significant stress and increase mental health risks. And then on top of not receiving help, it just kind of snowballs there. Overall, culture plays a major role in how people cope and whether they seek help, which is why culturally responsive care is so important.
Okay, looking at acculturation and within group differences. When we talk about different cultures, it's important not to assume that one shared set of beliefs or behaviors encaptures the entire culture. So there's research showing that acculturation and inculturation influence help seeking indirectly, especially through perceived beliefs and barriers to care. There is a 2024 study of mostly Mexican American college students that greater acculturation was linked to greater perceived benefits of seeking care, which in turn ended up predicting stronger intentions to seek help for depression. Inculturation itself was not a simple risk factor, which shows how nuanced the issue can actually is. Within group differences matter because people from the same broad culture might still have different values, symptoms, expression, and willingness to seek treatment. Research also shows that shared family and group-oriented values like independence and familism can reduce the likelihood that someone identifies a need for treatment, even when the distress is present and causing problems in their lives. These values can be protective, but they also sometimes make professional help seeking feel like it's something to be ashamed of, it's unnecessary, or it's disloyal to the culture that they are a part of.
Perfect. Moving on to views of others with mental health illness, cultural beliefs strongly influence how individuals view others with mental health illnesses. In some cultures, mental illness is seen through a medical lens, while in others, it may be viewed as more of a weakness or weakness of like your morals or even a spiritual issue. These beliefs affect whether individuals receive compassion or are blamed for their conditions. This directly impacts levels of social support or isolation depending on what culture the person is from. When stigma is high, individuals may be less likely to seek help or follow through on treatment or even dismiss the illness as a whole. They might not even believe it is something that is real and actively affecting them. Understanding these cultural differences help providers reduce stigma and improve engagement in care by taking into account the own person's culture and beliefs.
Okay, next up, kind of continuing down that same track with stigma and mental health in the US. This slide centers on stigma as a global and deeply embedded issue in mental health and how it intersects with identity. So first, it's important to note that stigma is not limited to one culture or region. Research shows it is pervasive across the world and shows up at every level of psychiatric care. It exists in public attitudes, within healthcare systems, and even in how individuals come to view themselves. This means stigma is not just external, it often becomes internalized. Stigma also intersects with identity in powerful ways. Factors like race, ethnicity, religion, and gender can shape how stigma is experienced. In the US, particularly, racial and ethnic minority groups, including Asian, Black, and Latinx communities, often report higher levels of both public stigma and self-stigma. Another example I have is in some Muslim communities, individuals may experience what we call double or intersectional stigma, which means mental illness may carry stigma on its own, but when combined with those other factors like religion, race, ethnicity, or gender, that burden can multiply, which makes it even harder to seek help. Gender also plays a role. In some contexts, women may perceive higher levels of stigma, especially when culturally based expectations around roles, behavior, or emotional expression are involved. And then across cultures, we also see common themes in how stigma operates. These include barriers to accessing services, family shame or pressure to conceal struggles, limited mental health literacy, and strong negative emotional reactions to mental illness. Now, to look specifically at the US, stigma has very real consequences. It can delay treatment, reduce access to care, and lead to lower engagement or adherence when someone does enter treatment. Ultimately, this contributes to worse mental health outcomes. On a more personal level, though, stigma often leads to shame. What's sometimes referred to as shame anxiety reflects a fear of embarrassment or rejection, not just in healthcare settings, but in everyday life. This is going to erode self-esteem and lead to individuals to internalize harmful stereotypes about themselves. Finally, stigma fosters silence and secrecy. Many young people in particular may hide their symptoms or even avoid taking medication in order to fit in socially. This is just going to be a huge limit in access to support systems and can increase feelings of loneliness and isolation. Overall, this is all a great reminder to us that addressing mental health requires more than treatment. It requires actively reducing stigma in culturally informed and compassionate ways.
Moving into the advocacy and reducing that stigma that Dylan just talking about, just talked about, mental health advocacy is focused on promoting the rights of individuals with mental health conditions and reducing stigma and discrimination. It works by addressing both structural barriers like access to care and societal attitudes that impact outcomes. Advocacy has played a major role in shaping mental health policies and improving services across different countries, making it a key driver of progress in the field. And that's what the World Health Organization said. Stigma is a major issue. It creates a sense of shame and can seriously impact a person's social standing. Because of this, many individuals avoid seeking help, experience isolation, and struggle with self-esteem, which Dylan touched base on too. Stigma can also lead to real-life consequences like difficulty finding housing, jobs, or healthcare, and it can negatively affect both individuals and their families. The good news is that there are actions that we can take to reduce stigma, including education, advocacy, and promoting more open conversations about mental health. And then on that slide also, there's a few more actions to fight stigma. So community awareness, education, sensitizing teachers, healthcare workers, psychoeducation, empowerment for patients. There's just a lot we can do, but getting that out there and again, just educating our communities on how to do so appropriately is would be the ultimate goal.
All right, moving on, we're going to be looking at neuroscience approaches to treatments, which is a topic that I personally find extremely interesting. So the neuroscience approaches to mental health are really working to shift the field from a symptom-based model to one that focuses on the underlying brain systems and functioning and what's going on that's causing these issues that the person might be facing. Instead of just looking at the disorder someone has, we're looking at what's happening in their brain and how we can specifically target that issue. So this has really worked to open the door to more personalized care approaches. For example, interventions like transcranial magnetic stimulation, aka TMS, uses non-invasive brain stimulation to target specific areas involved in mood regulation, and this is often used for treatment-resistant depression. There's also ketamine and esketamine that's gaining attention as fast-acting options for individuals who haven't responded well to traditional antidepressants. These approaches both work differently than standard medications, but they can provide relief more quickly for some individuals. There's also growing research focused on identifying biomarkers and using tools like digital phenotyping to predict which treatments might work best for a given person. So this area is still developing, but it does show a broader shift towards matching specific treatments to the individual instead of the trial and error approaches that we've used for so many years. For community health providers, the goal in this is to be aware of these options and understand when a referral might be appropriate. So providers play a critical role in early identification, psychoeducation, and reducing the stigma around the advanced treatments. A lot of people become kind of hesitant or fearful about newer inventions and treatments. So providers having a basic understanding of how they work really helps helps them explain the options in a way that makes it feel safe and accessible to clients who might be nervous otherwise.
Perfect. Moving on to how we can mix this faith and mental health, we all are aware that this is quite the complex topic because faith can play a really powerful role in mental health for many individuals who use faith as a coping mechanism and ways to find meaning during difficult times. Some practices are prayer, reading scripture, and engaging in faith communities can provide comfort, support, and a sense of hope for an individual. For Christian counseling, integrating faith can strengthen treatment by aligning with the client's values. However, it's always important to avoid spiritual bypassing, where spiritual explanations are used to avoid addressing real emotional or physical concerns. A balanced approach respects both faith and evidence-based mental health practices to ensure that we are providing the best care possible for our patients. It's also important to never bring this up yourself very first thing. This is always should be something that is done naturally with the client and the counselor having healthy and happy conversations during treatment.
Yes, and to build right off of that, this slide is going to focus on how to thoughtfully integrate faith into mental health care, especially within the diverse client populations we've been talking about. So just like I will echo Savannah saying, we let the client take the lead. Spirituality can be deeply personal, so it's important to respect each client's pace and comfort level when it comes to integrating faith into the counseling process. So our role is not to impose any of our own stuff, but rather to follow their cues and honor their autonomy. That also means avoiding the temptation to project our own interpretations, beliefs, or practices onto the client. I think this is a really important part. Even within the same faith tradition, say that I'm a Christian and so is my client, our experiences and understandings can vary widely. So we need to try to keep those separate. When it is appropriate and invited, scripture can be a meaningful resource. We've got a couple here. Galatians 6:2 encourages us to bear one another's burdens, which aligns with the supportive role of counseling. Similarly, Elijah's experience in 1 Kings 19 reflects deep emotional despair, even among the strong figures that we see in the Bible of faith, and that highlights that struggle is not incompatible with belief. It's also important to frame mental health really carefully in faith contexts. Mental illness is not a sign of weak faith or spiritual failure. I feel like that's a huge religious wound that a lot of clients may bring. Instead, it can be understood as part of the broader human experience, our brokenness and need for care, support, and healing. At the same time, we want to acknowledge that religious culture can sometimes create barriers. So messages, intentional or not, can discourage people from seeking help, which increases shame or promotes silence around mental health struggles. So overall, again, definitely complex, like Savannah said, is integrating faith and counseling, and it's going to require cultural humility, sensitivity, and a deep respect for the client's individual spiritual framework.
All right, so moving into the application for community providers. Cultural competence is made up of multiple parts, not just one skill. According to Sue and colleagues, it includes our attitudes, knowledge, and skills. So first, we need to be aware of our own biases and then how it might impact our work. Then we need to understand our clients' cultural backgrounds and the systems that affect them. Finally, we have to apply that understanding in a way that's respectful and appropriate in practice. So combining all three parts together. This also ties into cultural humility, meaning we stay open-minded and continue learning from our clients. Overall, cultural competence is not something that we fully ever achieve. It's something that we're always developing as counselors. Trauma-informed care focuses on creating environments where clients feel both physically and emotionally safe. It recognizes how common trauma is and emphasizes understanding its impact, identifying signs, and responding in ways that avoid re-traumatization for the client. Trauma-informed care is guided by principles like safety, trust, choice, and collaboration. It also requires changes, not just at the individual level, but across the entire organization. The benefits of this treatment are significant. For clients, trauma-informed care can lead to better engagement in services, improved mental health outcomes, and a reduced risk of being re-traumatized. Clients are more likely to feel heard, respected, and safe within this type of treatment. For providers, it can reduce burnout and compassion fatigue by creating more supportive work environments. It also improves the communication, teamwork, and overall effectiveness in care.
And to finish off our presentation today, we're going to look at just a little call for action. Culturally responsive, my goodness, mental health care requires more than clinical knowledge. It calls for humility, advocacy, and a commitment to seeing the entire person. As providers, we are uniquely positioned to reduce stigma, honor diverse experiences, and integrate approaches that address the mind, body, and spirit. By doing so, we move beyond treating symptoms to supporting healing. To care for the mind, we have to understand the entire story behind it.
And then here are our references as well, and thank you so much.